Hey class, welcome to this lecture on sodium fluoride PET-CT skeletal imaging. These are the objectives for this lecture. We're going to talk about skeletal imaging and PET-CT, specifically with sodium fluoride, including any adjunctive medications. There really aren't any specifically, but we're also going to identify the appropriate indications and contraindications, describe the imaging protocols, discuss normal biodistribution, and pathology. So sodium fluoride is very similar to MDP. It is imaging of the skeleton with PET or PET-CT, and it can be accomplished using F18 sodium fluoride. So this has superior resolution compared to planar imaging, and it can detect metastases from several different primary cancers. This imaging here shows an ill-defined region of patchy osteosclerosis involving the left ischium and inferior pubic ramus. You can see it right here in the pelvis. It is intensely fluoride avid, which means it's hyper metabolized and taking up a lot of fluoride. And there is a 1.2 centimeter rounded sclerotic region in the anterior column of the left acetabulum. See that down here. Sites of fluoride activity are visualized elsewhere in the skeleton, localized to degenerative changes, and on co-acquired CT scan. So really nothing that specific. You see some activity here. This in the kidneys is normal. You see some in the spine, pelvis, and then down there. And this is the MDP version of the same patient. So we're going to do a couple different cases where we compare the sodium fluoride PET-CT study to the good old 99 MTech MDP HDP studies, so you can see the difference. So sodium fluoride is used for bone imaging of areas of altered osteogenesis. The mode of localization is chemoabsorption, and typical adult dose is 8 to 10 millicuries. There are a couple different ways to calculate the pediatric dose, but typically it's a half a millicurie minimum, regardless of the patient's weight, age, or size, and then 4 millicuries maximum, which is half the adult dose, just because babies or children are more radiosensitive. And then the typical calculation that can be used is 0.05 millicuries per kilogram, but at the end of the day, it still needs to fall between these minimum and maximum levels. Some of the details of the radiopharmaceutical. It is tagged to F18, so it decays by positron emission with a half-life of 109.7 minutes, roughly 110 minutes. 97% of the decay results in emission of a positron with the energy of 633 keV, and 3% of the decay results in electron capture. It's pretty typical for all fluorine. And then you have the 511 keV annihilation photons, which are actually what we image. The mechanism of uptake or mechanism of action for this one is it's normally accumulates in the skeleton in an even fashion with greater disposition in the axial skeleton, like the vertebrae and the pelvis, than in the appendicular skeleton, which would be the bones around the joints, the arms, the legs. Now, fluoride F18 diffuses through the capillaries. Sodium fluoride, diffuses through the capillaries into bone extracellular fluid space, where it becomes bound by chemoabsorption at the surface of the bone crystals. So mechanism of uptake or mechanism of action is all of that, basically. It binds to the bone crystals, preferably or preferentially at the sites of newly mineralizing bone, and it actually becomes a part of the bony matrix. The method of localization then is chemoabsorption, and it's chemically absorbed into the bone and bony matrix. Indications for sodium fluoride bone scanning are pretty much the same as any other bone scanning that you've already learned about. Um, and we'll talk about that in a little bit also. There aren't any absolute contraindications for sodium fluoride studies. Pregnancy and nursing are listed there, but those are not absolute contraindications. Of course, the risks and benefits need outweighed with the patient, and the patient needs to be able to make that decision along with her doctors and the ordering physicians. Nursing, breastfeeding is not an absolute contraindication either. It is recommended to pump and waste for about 12 to 24 hours, depending on your facility's protocol. Now, it's not necessarily excreted through the breast milk, but the mother would be radioactive. So holding the baby while nursing may be a problem and is recommended to bottle feed for that first 12 to 24 hours. Administration is typically 8 to 12 millicuries administered IV in adults. It is stored at room temperature. It expires within 12 hours of being made. Critical organ is the urinary bladder. It is excreted through the urine, so you will see kidneys and bladder just like you do on MDP and HDP bone scans. And the areas of normal uptake then are bones, the kidneys, the ureters, and the bladder. So indications for sodium fluoride bone scan, this is not an all-encompassing list. Anything that it's affecting the mineralization, the uptake, remodeling of bone could be used for sodium fluoride imaging. So typical indications are, of course, looking for metastatic disease, but back pain and otherwise unexplained bone pain, instances of child abuse, abnormal radiographic or laboratory findings, osteomyelitis, trauma, inflammatory and degenerative arthritis, avascular necrosis, osteonecrosis of the mandible, condylar hyperplasia, metabolic bone disease, Paget's disease, bone graft viability, complications of prosthetic joints, or any kind of application of hardware, reflex sympathetic dystrophy or RSD, and distribution of osteoblastic activity before administration of therapeutic radiopharmaceuticals for bone pain. So this would be ordered before like a Xofigo therapy or anything like that where you're looking at therapy going to the bone. When you're taking a patient history, it's very similar to the history you would take for MDP or HDP bone scan. You want to know anything that's ever happened to their bones, history of trauma, orthopedic surgery, cancer, osteomyelitis, arthritis, radiation therapy, or other localized conditions that would affect the bone. Relevant laboratory tests include getting the PSA levels in the blood in patients with prostate cancer, looking at the alkaline phosphatase levels. That would indicate maybe that they have a condition that's pulling the phosphate from the bones, and results of prior imaging studies that should be reviewed. And that would be plain film x-rays, CT, MRI, other bone scans like MDP bone scan, and then of course any other PET studies. If they have prostate cancer, they may have had a fluciclovine or a PSMA study, and of course FDG as well. The patient should be well hydrated to promote rapid excretion of the radiopharmaceutical. This decreases the radiation dose, but it also improves the image quality. And then, unless contraindicated, patients should be well hydrated. So, drinking 2 or more 8-ounce glasses of water within 1 hour before the exam, and another 2 or more glasses after administration of the radiopharmaceutical. So we want them to encourage them to drink a lot of water. Patients do not need to be NPO for this study, but a lot of times they think they do, which means they didn't drink any water. It's okay to go ahead and give them something to drink before they get started. Patients should be instructed to empty their bladder frequently and especially immediately before imaging. And appropriate precautions for proper disposal of radioactive urine should be taken in patients who are incontinent. That's really important. If the patient's incontinent, you want to put lots of chucks down on the table underneath of them. And that way, if they do have an accident on the table, it won't contaminate your table. You can just clean up the chucks. Patients do not need to fast, like I said, and they can take all their medications as usual. For the protocol, patients will be injected with 8 to 12 millicuries IV. It is a good idea to start an IV or at least a butterfly to make sure that the dose goes in and isn't infiltrated. It's also a good idea because you don't want to really be handling it more than you need to be. The uptake time is at least 30 minutes for the whole body. So this does uptake quicker than the MDP studies, which are usually 2 to 4 hours. So if you're scanning the extremities, then it requires 90 to 120-minute uptake, just because it takes a little longer to get into the smaller fine bones. And diabetic patients and patients with renal failure may also require longer uptake times. But typically 30 to 45 minutes is great. Some departments will just go for an hour because that's what they do for FDG studies also. You want to have your patient void right before imaging. There's no need to give any kind of oral contrast because you're just looking at the bones. And then place the patient supine on the table, arms down if they're able to. If they're not able to, and it's not that important for what you're imaging, then they can be above the head. And then the CT scan is done for attenuation correction purposes, followed by the PET scan. The PET scan is vertex to toes, so you do the very top of their head all the way through their toes. You want to get their entire body. This is typically done in 3D mode. This improves the sensitivity of the instrument, not of the radiopharmaceutical to find disease, but it improves the sensitivity of the PET scanner because you're getting more counts that way. And then typically you go for 2 to 5 minutes per bed position. If you are scanning in 3D mode, you can go for 2 to 3 minutes per bed position and shorten the time a little bit. This is crucial in patients that are experiencing a lot of pain and it may be difficult for them to lay down that long. For processing, it is done via iterative reconstruction with CT for attenuation correction. This is either OSEM or MLEM, and for the iterative reconstruction method. And then images are displayed in maximum intensity projection with the whole body cine plus coronal, sagittal, and axial views for the CT, the PET, and the fused images. So this is the normal biodistribution of a sodium fluoride bone scan. It's seen in the skeleton and urinary tract. Increased uptake on the soft tissue would indicate more uptake time is needed or possibly decreased or delayed localization due to renal disease. You'll notice that there's a lot higher target to non-target ratio in sodium fluoride bone scans than what you have seen with MDP bone scans. So I have a couple studies comparing the sodium fluoride bone scan to MDP, since you are already used to MDP bone scans. This is an example of a 66-year-old man with a history of prostate adenocarcinoma. He was seen for evaluation of bony metastases after androgen deprivation therapy and definitive radiotherapy. Image A and B are the sodium fluoride study. And then they show normal physiologic biodistribution, mild scattered degenerative changes are seen in the spine, but nothing of concern. And then C and D are the anterior posterior views for the 99M technetium MDP bone scan of the same patient performed 3 weeks earlier. And this also shows normal physiologic distribution. So both scans show no metastatic lesions and are good examples of a normal. But I want to point out a couple things to you. Of course, one is the increased spatial resolution that you get with the sodium fluoride. And that has a lot to do with the target to non-target ratio and just the physics of how PET is imaged in the PET scanner. Remember that with the MDP and bone scans, you're scanning anterior and posteriorly, with the camera slowly moving down over the patient. So it's not spending a lot of time over any single anatomy, and you're only imaging in one plane. Whereas with the PET scan, you're imaging all the way around the patient. You're getting a lot more counts per time and per anatomy. And so just the physics of that, you have a lot more counts, but you also have a better target to non-target ratio. You see a lot more detail in the spine than in the ribs than you see on the MDP study. And then also, if you look at the degenerative changes around the patient's heel and their feet, it shows up a lot clearer on the PET study. Now, this one is a 56-year-old man with newly diagnosed prostate cancer. His PSA is actually almost 3,000, which is extremely high. He underwent both conventional whole body bone scan and the with 99 MTEC MDP, and then a whole body PET CT with sodium fluoride. There's about 20 days in between. Both tests were done for staging purposes. A and B are the anterior posterior of the MDP bone scan, and this was negative for bone metastases. C is the maximum intensity projection image for the sodium fluoride PET scan. And there are a couple red arrows there that I want you to pay attention to. One is showing sodium fluoride avid lesions that are located in the cervical spine. And then the other one is pointing to the lateral left rib. The axial CT images and fused images are seen in D through G. And this corresponds to the osteosclerotic lesions at C5. Strongly indicating that this is metastatic lesion. F and G are the axial CT images of the thorax, showing abnormally increased sodium fluoride activity at the lateral left rib. And this is corresponding to a hardly seen on CT lesion, highlighting the capability of the modality to target early stage metastatic lesions. This would have got missed probably on CT, and MDP if it was just used as an MDP scan and then CT. But having the sodium fluoride PET CT study, it does correspond with something that is very faint on the CT, but lights up really well on the sodium fluoride study. And so this is a good example of metastatic disease that would have been missed if the sodium fluoride PET CT study had not been used for this patient. This one is a patient with prostatic adenocarcinoma after they had their prostate removed, and the patient underwent salvage radiation plus therapy with hormone-releasing hormone antagonist or agonist for 6 months, with PSA being undetectable for about 2 years. After that, he had an increase in the PSA levels, and the patient underwent both conventional whole body bone scan with MDP and whole body PET CT with sodium fluoride. A and B are the anterior posterior views of the whole body bone scan, and this revealed a metastatic lesion in the right sacrum, right where the arrow is pointed to. And then C is the whole body maximum intensity projection of the sodium fluoride PET CT study, and it shows abnormally elevated foci in the right sacrum with additional lesions at the thoracic vertebrae and at the right iliac wing, which the green arrow is pointing to the right iliac, and the blue is pointing to the thoracic region. The CT fused images of the thoracic spine show intensely increased sodium fluoride uptake, which does correspond to the lesion around the body of the T5 vertebrae. And then images of the pelvis are down there showing abnormally increased activity in the right iliac wing, colocalizing with the lesion seen on CT. So H and I down here at the bottom are axial CT and sodium fluoride images of the pelvis, and it shows abnormally increased activity in the right sacrum. So all of those areas that we're seeing on the maximum intensity projection images did correspond to metastatic lesions. This is the next one. This is a case of a 62-year-old man with a history of prostate cancer. He was evaluated with both whole body MDP and sodium fluoride whole body bone scans before the initiation of therapy, and then followed up 6 months after therapy completion in order to evaluate the treatment response. So he had both studies pretty close together, and then both studies again 6 months later. They were, I'm sorry, both scans were only performed a day apart. So you see A is anterior and posterior of the whole body bone scan with technetium, and it does show extensive skeletal involvement. And then B is anterior posterior view of the tech bone scan 6 months later, and it does indicate stable metastatic disease. It did respond to treatment. C is the baseline whole body sodium fluoride PET, and it reveals more osseous metastatic sites seen on the MIP image than we're seeing with the MDP. The sodium fluoride study that was performed 6 months later is shown here in D. That one did show improvement also with decreased sodium fluoride activity in the majority of the skeletal lesions. The appearance on the CT portion of the study was almost resolved for several of the bone metastases. So this is another example here of MDP compared to PET. These first two images here, anterior, posterior, are the TEC MDP images. And then the one here on the far right is the sodium fluoride study. I want to point out that there is some increased activity here in the pelvis that you can really barely see on the MDP studies, but you see it a lot more pronounced on the PET CT. And then that also corresponds to area that was seen on the CT as well. You compare the right and left on the CT image, you'll notice that that lesion is a lot bigger and dense seen on CT, but it's not real specific for what it is. And then if you combine it with the sodium fluoride images, you can see that that's the area of increased uptake. This one is conventional MDP planar that shows several bone metastases in the right scapula, the lower left rib cage where the red arrow is, and in the right proximal femoral shaft, which is where the blue arrow is, in a patient that has prostate cancer metastases. Image B is the sodium fluoride PET scan that was obtained shortly afterward. It clearly shows a greater burden of bone metastases than what was seen on the MDP study, especially in the rib cage, the spine, and the pelvis. This is an example of where the sodium fluoride is much more sensitive to changes in the bone and bone breakdown and bone development than the MDP is. Part of this does have to do with PET imaging and just the spatial resolution and the sensitivity of PET scans and just the image quality that you get in PET versus the planar imaging with tech-based agents. But it also has to do with the difference that one is a phosphate and one is fluoride. But a lot of it has to do with just being PET imaging. So this is a chart comparing the two. The half-life is shorter for sodium fluoride. It means it's going to spend less time in the body. It's going to decay quicker. That translates to lower radiation exposure. Spatial resolution is much higher than it is for planar imaging with tech-based agents. PET scanners are just a lot better spatial resolution than gamma cameras anyway. Critical organ is the bladder for sodium fluoride. It's bones and bladder for MDP. Bladder still gets a lot. The typical dose is a lot less for sodium fluoride. You can give a lower dose and still get better quality images than you can with MDP. Injection to image time is different also. With sodium fluoride, it's about 30 to 60 minutes from the time you inject them to the time you put them on the scanner, whereas MDP really needs to wait 2 to 4 hours, with most people waiting about 3. And then, so the effective dose is much different. This chart is comparing MDP and sodium fluoride sensitivity and specificity for prostate cancer patients. I do want to note that the sensitivity and specificity will change dependent on the pathology that we're trying to identify. But overall, across the board, sodium fluoride has more sensitivity and specificity than the 99M tech-based skeletal imaging agents. So if we take a look at this chart, remember the sensitivity that we're referring to isn't the sensitivity of the detector, it's the sensitivity of the radiopharmaceutical to be able to detect disease. So if there are osteogenic changes, will we be able to see them? The sensitivity for MDP is only 70%. When we add SPECT, that does go up to about 92%. But with sodium fluoride PET, especially PET CT, it's 100%, which means if there are any osteogenic changes anywhere in your bones, the PET CT study will be able to pick that up. Now, specificity is a little bit trickier. That's always been poor with bone scan imaging. That's the ability to say, differentiate between different pathologies. So let's say that somebody has a hot spot that's showing up in their femur. We cannot tell if that is a metastatic lesion, if it is infection in the bone, if it's osteomyelitis, or if it is a fracture or arthritis. We can't really tell what it is. We can just tell something is there. Bone scans are always bad at that. We can tell what the changes are, but we can't specify. So with MDP, it's only 57%. With MDP SPECT, it does go up to 82%. With sodium fluoride PET, it's 62%. But when you add PET CT, that increases significantly. So these studies are extremely sensitive and specific when you add PET CT. And so this last image here is just a CT PET portion and then fused skeletal imaging. The cool thing about that, when you fuse it with CT, you see all the internal organs from the CT, but only the bones are actually lighting up because that's where the radioactivity is. So with all the advantages of sodium fluoride being more sensitive, more specific, just better image quality. A couple case studies that I showed you, it really does improve the outcome and the treatment plan for patients because you find metastatic disease that you would have missed on a regular bone scan. However, MDP is still the scanning method of choice. Not by choice, really, I shouldn't say that, but it's the one that's still a lot more common than sodium fluoride bone. A lot of that has to do with the availability of the sodium fluoride bone scans, but most of it has to do with a lack of reimbursement, and insurance companies, even though it's less radiation, it's better on the patient, all around just better in so many ways. There's problems with reimbursement and with availability, and without being able to prove that PET is the better test, insurance companies would still prefer to pay for the MDP study because it is cheaper. So that's been a huge hurdle for sodium fluoride bone scanning. I hope you guys do get to see it in your careers, and I hope it takes off a little bit more because it really is a great imaging tool. And that's it. I hope you guys enjoyed this lecture, and I hope you get to do some sodium fluoride bone scans in the future. Thanks for watching.